This story shows a different way to approach the end of life, certainly different from how I was trained and how many people continue to be trained. Stephanie Rovid, her name is Marcia Green in the epilogue, but her real name is Stephanie Rovid. She was a 60-year-old wife, mother, grandmother. This was an exuberant woman. She loved life. She loved gardening. She loved wine tastings. She loved her family. When she was diagnosed with lung cancer, she vowed to fight it with everything she had. She stopped smoking. She started exercising. She started making these green smoothie concoctions that apparently were disgusting to boost her immune system. And she said to her oncologist, "Bring on any and all chemotherapy." And he did. And she went through many, many cycles of chemotherapy. When she found out that the cancer had spread to her brain, she just was determined to fight harder. What Stephanie didn't realize was that cancer at this stage isn't curable. She thought that if she just worked harder, took more chemotherapy, she could beat it. And so she did. And by the time I met her on my service in the ICU, she was in shock. Her blood pressure so low we could not measure it. And she was on death's door. My team and I worked fast, and we jacked up her blood pressure, luckily before too much damage had been done. And the next morning, she was back. Success! But I couldn't celebrate because I knew that it was just a matter of time before her blood pressure, like a leaky tire, went down again. Stephanie needed the facts, but I didn't really want to tell her. Do you know that her kids were treating her ICU room like it was Command Central, and they had actually taped up a sign that said, "No bad news." And in addition, didn't they deserve a break? This family had just been through so much. Couldn't the team on the floor tell her in a couple of days when things had settled down? But you know what? Deep down, I knew they weren't going to tell her. This woman had been in and out of our hospital multiple times over the previous couple of months, and she had no idea what was going on. And then the nurse walked up to me. And I thought she was going to say, "Hey, we need the bed." But she didn't. She looked at me and she said, "I think you need to tell her." And I said, "You're right." And I really didn't want to, but I walked into her room. And when I got there, Stephanie's daughter, Becky, was giving her a pressure point massage for strength. It actually reminded me of like getting a boxer ready to go back into the ring. And Becky looked at me and she said, "What's next? We're ready to fight again." And Stephanie looked exhausted, but she nodded. I sat down on the side of her bed. I was very nervous. I had to force the words out. And as I was talking, Becky stopped massage mid-pressure point, and she was glaring at me. And Stephanie, her facial expression completely had changed, and I couldn't tell if she was getting ready to scream at me or start sobbing. And what happened was almost worse. Becky looked at me and she said, "Please leave." They transferred out to the floor, and I couldn't stop thinking about it. I felt horrible. I felt I'd failed them on so many levels. But I couldn't stop thinking about them, and I knew I needed to go and check on them. And so I went to her room on the floor. I was dreading it. But I reached her room. I was in for a big surprise. Because there was Stephanie. She was sitting in her wheelchair, and she was smiling. And her husband was packing up her room. She had her iPad on her lap, and her daughter Becky was at her house, at Stephanie's house, talking to Stephanie on the iPad. And it turned out they had done a complete about-face. And I want to show you a quick clip of that moment.
Looking at my bed set up in my living room at home.
Yeah.
And it's one of the hospital beds, but my daughter has got it fixed with my quilt from home, which is my favorite one to sleep under. The dining room table has room to extend out so everybody can come and still visit, and I cannot wait to get home.
You tell me what bottle of wine you want, Mom. I'll crack it open and let it start breathing right now.
That's right. Well, I'll tell you what, I want something nice, so we'll start with a light red one. And then we'll also pick a heavier red one for later in the evening. Do the things that we love to do. We retired early. My daughter's quit her job. I'll fly wherever you are,
Fabulous.
so that we can spend this last year doing the things that we love to do. I had no idea that I had choices or the power to say, no, I don't want to do this, I want to do this. Or I didn't know these options were out there. I want to drink a glass of wine. Have
A lot of glasses of wine, good.
Fruit, little cheese, sit at my dining room table,
Aww.
and talk with my friends and my family.
You mean you're not going to want to sit here in this bed here?
No.
Joe, what do you think?
Ever done.
Bringing power to people like me that I didn't know I had that kind. I didn't know until a doctor told.
Yep.
Well, I didn't,
Yeah.
So they had heard what I had said. They had taken it in. And apparently the next day after transferring out of the ICU, they had met with Hospice. And they decided to go home. No more hospital. In the end, they chose Cabernet over chemotherapy. Stephanie enjoyed the last 2 months of her life with the support of Hospice, her family, and several bottles of good wine. And her funeral, which I attended, was filled with wonderful stories and not 1 ounce of regret. The last couple of months of Stephanie's life could have looked very different. She could have gone on to that last stop on the end-of-life conveyor belt. But she chose not to. We couldn't save Stephanie's life, but we did save her humanity. And I've come to see that as a new kind of heroism. It's an approach that sees patients as people, not a series of fires to be extinguished. I know that everyone in this room knows that most patients aren't as lucky as Stephanie. They don't ever get the chance to opt out. So I want to finish up by giving a few strategies that I think will help make stories like Stephanie's more the rule than the exception. First, let's redefine success. I used to think that success could only mean fighting the disease and winning. Our patients are going to follow us into battle if that is the only option we give them. But over these past 15 years, I have learned of many other types of success. For patients like Stephanie, being home with family, being at peace, physically, spiritually, not dying on machines. And for doctors like me, the success of treating a patient the way she tells me she wants to be treated. Stephanie got to define success here, not us. Second, let's be honest. There is a huge elephant in these hospital rooms. Patients and doctors on completely different realities. I'm going to show you some data that shocked even me about patients who were on the verge of receiving a tracheostomy because they were too weak to come off the ventilator. Their loved ones actually thought the patient would do really well over the next year. Here's some of the data. 93% of them thought that they would be alive. 71% thought that they'd actually be living independently. And 83% of them thought that there would be a good quality of life. But the physicians, they thought very differently. This discrepancy is chilling and unacceptable. The physicians were much more accurate about what was going to happen, and yet it was the loved ones who were entrusted to make a decision for a surgery that almost always remains permanent and is actually the first step, I think, on the end-of-life conveyor belt much of the time. Why is this happening? I had to write a whole book about it. It's very complicated. But I think one of the biggest reasons is that doctors really have a hard time breaking bad news. I think it's one of the hardest parts of my job. Remember Stephanie? I almost didn't go back in her room. And I'm a palliative care physician. Doctors, we need to tell our patients the truth. They can't plan for a good death if they don't even know they're dying. Good communication skills have to be thought of as important as running a good code or putting in a Quinton catheter. Patients and families, you also have a role to play here. Think about this. Do you want to know what the doctor is really thinking, or do you just want to have good news? That's an important question to ask yourself. Because if you want good news, that's probably what you're going to get. Let's now talk about one final critical element for a humane approach to the end of life, a non-conveyor belt approach to the end of life, and that is collaboration. The hierarchical system that runs many of our ICUs and hospitals isn't working. My two greatest mentors have not been doctors. It was a nurse, Pat Murphy, who taught me that it was okay to learn from others, that it was okay to ask for support. And it was a chaplain, Betty Clark, who I've worked with for 10 years, who taught me that the doctor often isn't the most important healer in the room. If we stick to this hierarchical approach, where the doctor's driving and everyone else is sitting in the back seat, we are just going to keep making wrong turns right back onto the end-of-life conveyor belt. We need a healthier, a humane medical ecosystem where patients are treated like people, and those of us doing this work can access our humanity. These three approaches that I mentioned will get us there. Redefining success. It's not about the protocol, it's about the patient. Being honest with our patients, our colleagues, and ourselves. And really working together, because it takes a village to do this very, very hard work. And it's not going to be easy, because culture change is hard. It's turning things on its head. It's scary. It's trying to learn skills that we're just not that good at. And frankly, it's making room at the table for other voices. But I'm optimistic. I really have seen firsthand that if we work together, we can create a new kind of heroism, one that I believe will save us all. Thank you. Thank you. Thank you. Thank you. Thank you.
Thank you so much.
Thank you.